Today we will study about pre-eclampsia and eclampsia condition. Toxemia of pregnancy encompasses pre-eclampsia and eclampsia, which are life-threatening complications of pregnancy, and deaths from these can be prevented by proper antenatal care and administration of magnesium sulfate. Pre-eclampsia and eclampsia can be prevented and managed by following: recording and monitoring blood pressure and urine examination of all laboring mothers, timely identification of dangerous signs, giving injection of magnesium sulfate in all mothers having severe pre-eclampsia and eclampsia condition. We will focus in pre-eclampsia and eclampsia in the following subsections. Pre-eclampsia. It is called hypertension with proteinuria. In pre-eclampsia, a pregnant woman presents with high blood pressure, BP more than 140 by 90 mm of Hg and less than 160 by 110 mm of Hg with traces of 1 plus or 2 plus proteinuria. Whenever a pregnant woman visits your center, you must take following measurements. Record the woman's blood pressure during every antenatal visit. If it has more than 140 by 90 mm of Hg, check it again after 4 hours. If the situation is urgent, the blood pressure should be measured after 1 hour. If the woman has hypertension, check her urine for the presence of proteins. If she has raised blood pressure and proteinuria, you can characterize the woman as having pre-eclampsia. Refer the woman to the 24 hours PHC or first referral unit so that she can receive antihypertensive medication. She should be managed at home as per the advice of the medical officer. Follow up the woman or her family and provide appropriate follow-ups. In case of high blood pressure more than 100 mm of Hg, antihypertensive drugs are given as per Government of Indian guidelines. Antihypertensive need to be given if diastolic BP more than 100 mm of Hg. Tablet alpha methyl dopa or tablet labetalol can be used for controlling blood pressure. Blood pressure should be maintained between 90 to 100 mm of Hg diastolic. In case of severe pre-eclampsia, use of tablet nifedipine or injection labetalol is recommended for initial control of blood pressure. Magnesium sulfate is given in severe pre-eclampsia to prevent progress of eclampsia. Follow-up care of a woman with pre-eclampsia. Advise the woman to come to you for a checkup twice a week regularly. Monitor her blood pressure and the fetal condition and urine for the presence of proteins. Encourage her to take rest. Encourage her to take a normal diet. She should not be advised to restrict her intake of salt and fluids. Advise her to go for an institutional delivery. Inform her family members to take her urgently to the PHC or first referral unit if there are dangerous signs such as headache, increasing in frequency and duration, visual disturbances, blurring, double vision, blindness, oliguria, passing less urine 400 ml urine in 24 hours, upper abdominal pain, edema, especially of the face, sacrum, lower back. Women who have a history of hypertension in the previous pregnancies have a greater chance of having a raised blood pressure in the present pregnancy also. So she should be referred. All the women should be referred to first referral unit and admit if they have BP more than 140 by 90 mm of Hg, proteinuria plus 1 or any other sign of pre-eclampsia. Next topic is eclampsia. Eclampsia is a life-threatening condition of pregnancy in which pregnant woman is having high blood pressure more than 140 by 90 mm of Hg with a 1 plus or 2 plus or 3 plus or 4 plus proteinuria and convulsions. Eclampsia is hypertension with proteinuria and convulsions. Convulsions that occur during pregnancy, delivery, or in the postpartum period should be assumed to be due to eclampsia unless proved otherwise. Eclampsia is characterized by convulsions, high blood pressure, a systolic blood pressure of 140 mm of Hg or more, and or a diastolic blood pressure more than 90 mm of Hg. Proteinuria plus 2 or more, headache and abdominal pain. Causes and risk factors. Actual causes is unknown, but the risk factors are as follows: elderly and young primigravida, family history of preeclampsia in mother or sister, poor diet, malnutrition, diabetics, multiple pregnancy, RH incompatibility, polyhydramnios, hereditary, smoking. Signs and symptoms of eclampsia: headache, hypertension, BP above 160 by 110 mm of Hg, edema, pitting edema over the ankles and a rapidly gain in weight of more than 1 lb in a week, visual disturbances, proteinuria, presence of protein in 24 hours, urine of more than 1 gram per liter, fits, abdominal pain, decreased urine output, signs of fetal distress. Care of a woman in eclampsia. Keep in touch with the woman or a family and undertake appropriate follow-ups of the cases. If the woman has convulsions, provide supportive care. The initial management of convulsions include the following: ensure that the airway is clear and she is breathing well. If the woman is unconscious, position her on her left lateral side to reduce the risk of aspiration, vomits and blood. Clean the mouth and nostrils by applying gentle suctioning and remove the secretions. Remove any visible obstructions or foreign body from her mouth. Keep a pad mouth gag between the upper and the lower jaw to prevent tongue bites. Do not attempt this during a convulsion. Administration: the first dose of magnesium sulfate injection. Keep her in the left lateral position. The first dose of magnesium sulfate injection is given to manage eclampsia. Inform the woman if she is conscious that she may feel warmth during the injection. Injection 10 ml, that is 5 gram of magnesium sulfate in each buttocks, a total of 20 ml, 10 gram. Ensure that this is given deep intramuscularly because otherwise an abscess can form at the site of injection. After receiving the injection, the woman may have flushing, may feel thirsty, get a headache, feel nausea or even vomit. Do not repeat the dose of magnesium sulfate. Do not leave the woman alone. The presence of an attendant is mandatory. Protect the woman from falls or injury. Maintain a record of vital signs. Immediately arrange to refer the woman to an first referral unit and ensure that she reaches the first referral unit as early as possible, preferably within 2 hours of receiving the first dose of magnesium sulfate injection. Accompany the woman to the first referral unit if possible. Manage any convulsions that may occur on the way. If delivery is intimated, you may not have the time to transport the woman to a first referral unit. In this case, deliver the baby after giving the first dose of magnesium sulfate injection. After the delivery, you must refer her together with the baby to the first referral unit for further management.